Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallace.
Hello and welcome to The View on GU, live on location in Niagara, Queen's Landing. We're at the Juravinci Cancer GU Oncology Forum, joined by my co-host on site, Christopher Wallace. We've had an excellent meeting this weekend covering really the composite of GU multidisciplinary care. Chris, it was great having you here. How's your weekend been so far?
Oh, it's fantastic. I think, the meeting this weekend has really represented in many ways the ethos of this podcast with, bringing together different perspectives, different specialties, different backgrounds with the goal of trying to really advance our space and improve the care for our patients. And I think it's been a great encapsulation of what we are trying to do in our professional lives. I think it's been awesome.
Absolutely. It's been great having everyone here. We certainly encourage folks to check out the JCC website for our meeting agenda and really importantly, the videos that were recorded. One of which was your talk, and we really appreciate you being here as an invited speaker, Chris. Just for a bit of background, we wanted to make that the focus of this podcast, was this concept about patient outcomes. And importantly, perhaps does the physician matter? And in particular, does the physician's gender matter? So maybe take us through kind of your high-level summary of the data, and we'll try and unpack this along the way.
Absolutely. I mean, I think if we take a step back and you say, does your surgeon matter or does your physician matter? I think intuitively all think the answer is yes, right? There's a reason why there's the whole notion of surgeon shopping. And we've known for many, many years that, surgical volume matters. People who do more of certain operations, particularly complex operations, tend to get better outcomes. So the idea that something about the surgeon or the physician treating you can affect your outcome seems intuitive. And the real question has been in the last maybe 5 or so years, and we were fortunate to be at the front end of this with some of our papers back in 2018, is surgeon sex or surgeon gender an important characteristic? This grows out of an old literature, maybe almost 20, 25 years old now, looking at processes of care, right? Things like how physicians practice. And so we know, women communicate differently than men. And that affects probably the way male and female physicians communicate with their patients. There's things like guideline concordance. And there's a bit of a gap from those processes of care to real patient outcomes. And so, our study was one of the first published in BMJ back in 2018, looking at those, hard metric for patients undergoing surgery. Do they have different postoperative outcomes? Things like readmissions, complications, mortality, based on their physician's sex. And we showed that they do. And so on average, there's about a 5 to 10% improvement in outcomes for patients who have a female physician. And that sort of varies based on what the endpoint is and what the study is exactly. But that's like the big ballpark, because in the surgical literature, our study was the first, as I say. We then had, close to a dozen subsequent studies, which have been fairly consistent. Obviously, there's some variation between studies, different contexts, different patients included, different healthcare systems. But when you sum them all together, at the 30-day endpoint, we're looking at about a 5% improvement in mortality for patients who have a female physician.
And let's just, kind of hammer that point home a little bit. You are producing data, and we're really live on site here, as people can hear. You're producing data for patients undergoing surgeries. Which of those surgeries are you talking about? Cancer surgeries as well? Does this apply to GU? Just so we know what kind of sandbox we're playing in with some of this data.
100%. So, I can comment most on the studies that we're writing, but the reality is that there's been, as I say, essentially a dozen papers on this. They all take a slightly different angle. So we've built what I would say is one of the most generalizable cohorts. So our studies are all built on a cohort here in Ontario, about 25 different surgical procedures, trying to represent all surgical subspecialties: thoracic surgery, neurosurgery, cardiac surgery, vascular surgery, general surgeons, surgical oncologists, urologists, ENT, obstetrics and gynecology. We're trying to, cover the spectrum. Clearly, we can't cover every procedure. It just becomes a bit cumbersome, but we've got, at least 2 or 3 procedures per specialty in urology, we're looking at things like cystectomies, prostatectomies, nephrectomies. Those are the kind of operations we're looking for, in part because we don't want the really small surgeries because their event rates are really low. And it's hard to study procedures where complications are very uncommon. And also those offer less opportunity for QI or actual improvement, right? You need to target the patient populations who are experiencing relatively high rates of adverse events, so that those are groups we can really make a difference on if we can change things. And so those are the kind of procedures we've tried to sort of hone in on.
The natural question from everyone in the crowd, and you created quite a buzz, and certainly for our viewers and listeners, is going to be why. But let me get to that a little bit later. Let's just zoom out and say, we've talked about surgical outcomes. You showed some data that this isn't just a surgery experience, that in medicine, there's other experiences that might be very common to viewers and listeners as well. Take us through the non-surgical experience where perhaps a treater's gender mattered.
Yeah, so there's, in addition to the dozen or so surgical studies, there's a similar number of studies across other specialties in medicine. Most of these fall into internal medicine. We've got some data in anesthesia. We've got some data in emergency medicine. I'd say, if we go back to the beginning of this, one of the sort of seminal papers that set this off was from Yusuke Tagawa in JAMA Internal Medicine, looking at, just hospitalized patients under hospitalist or general internal medicine teams. And he showed a consistent, reproducible decrease in 30-day mortality for patients admitted with things like COPD, CHF, pneumonias, cellulitis, those kind of common bread and butter internal medicine diagnoses. And so we've saw, from that kind of context, in our own studies, we've looked at anesthesiologist sex. And so for these patients, again, undergoing similar surgeries to I just described for the surgical cohort, the effective anesthesiologist sex also matters. Again, patients who have a female anesthesiologist tend to do better than those who have a male anesthesiologist. The effect is somewhat smaller there than for the surgeon. And then one of the sort of most compelling studies, I think, comes out of the emergency department literature.
I love that.
You got, there's always concerns about a selection bias and how patients and physicians come together in pairs in the surgical world. But when you present to the emergency room, the patient is not picking their physician. They just get whoever's on. And so out of the Florida emergency medicine system, we see patients who are presenting with an MI to the emergency room are less likely to die if the ER doctor on staff who's treating them is a woman.
Yeah.
And I think that's as close to a randomized trial as we're going to get for this question. And so I think it adds real credence to the fact that this is a real phenomenon. This isn't a sort of statistical manipulation. This isn't, some capturing of, just a series of biases or confounding. But really, I think we're seeing a true effect, and it does appear to permeate across all of medicine and all subspecialties.
Yeah, I was quite impressed by, well, first of all, the zoom out showing meta-analysis. So you had this kind of treatment effect and really showed across multiple studies, large data sets, 6 or 7 finger patients involved. And then this patient gender and physician gender, feeling seen and heard, which we'll get to. And, how does that match in the emergency department, which, as you say, is a bit of a randomization in its own way. This is medicine, and I think this topic in this podcast is going to be great because it's actually more about behavior and really beyond just medicine on itself. But what about if we take a further zoom out? How about examples in the non-medical world, business world? As you prepared this data for analysis, I'm sure you're curious about other non-medical examples. What can you share with us on that?
Yeah, for sure. So, I think there's been a lot more lay press interest in this research than any of the stuff I do in prostate cancer, for example. And I think that's because people view this as an experiment happening within medicine that reflects a greater societal phenomena. And so there's many examples in sort of across context. I think business world offers us 2 real insights. Number one is that when you look at startups, women who have startup companies get less funding in general for their startup from VCs and other organizations, and yet they get a much higher ROI on their startup.
Interesting.
So they deliver a greater bang for their buck, even though they're starting off behind the 8 ball. They get less startup, and yet they get further ahead. And so that's sort of one example. And then the question is, when we move from trying to quantify what's going on out there to thinking about how do we address the presumed underlying biases that are driving these differences, there's other great examples from the business literature where we have to consider, who the message comes from really affects the receptiveness to the message. And, anecdotally, the surgeon, the chair of surgery in Toronto is a woman. Carol Swallow is a phenomenal cancer surgeon. And when I've given these talks in the Toronto environment, she'll say to me, like, the audience is more receptive to this topic when you give it as a white guy than when I do as a senior woman in surgery. And so there is something about who the mouthpiece is that affects the receptiveness to us. And the business literature gives us great examples where women, and certainly people of color or other minorities, when they try to advocate for women or other people of color, they get penalized in a way that white men don't. And I think that it's been one of the things that really, I think, has allowed me to carve out a little niche here, because for whatever reason, when women advocate for women or when minorities advocate for minorities, there's a bit of a perception, at least that I view, that there's a self-interest involved.
Yeah.
And so when when I stand up there as a white guy and I say, you know what, men are underperforming here, we've got something to learn from our female colleagues and we can do and be better, it doesn't seem self-interested, I suppose.
Yeah, and we can dovetail there and get back to the why of your findings. But I'd agree. I mean, it struck some of us sitting there, and certainly as a minority, not a white man, so I don't have that privilege. But thinking about those advocating, and yet we think about those, as Carol Swallow and others who are, and let's be honest, I mean, these are largely 50s and beyond white males who are in a lot of division, department, and chair roles. And, one wonders that interplay between obviously being an ally, but the advocacy is coming from someone that has privilege, that it's possible as EDI or DEI rolls out across many hospitals and frankly, business corporations, are we really advocating for some groups to catch up, or are we kind of shifting deck chairs when really the leadership roles are held by the same privileged folks? So I take your point that there's this both kind of interest that we have on raising everyone's bar versus the self-interest that it might be seen as. Is it job preservation? Is it true allyship? What you led with saying, does it take someone to have a daughter or a sister to actually care? And is that necessary for this kind of empathy? And so I think, you raised a lot of other topics that, we can't fully unpack here, but I think makes a lot of us think about that when we see this in really common day-to-day scenarios. So let's maybe pivot back to the why, because I think that's the thread I really want to pull on. And I'll float you what our table was kind of talking about as you were giving this, because all of us just looked at each other, and it was just a perfect talk to have. It made us all sit back and think a little bit. So let me float you a potential scenario. You tell me if this is something you align with. But is there a bit about who is kind of able to enter the door, so to speak, on surgical specialties? So if you look at men and women, mostly more men, obviously, in surgical specialties as a whole. The women who are able and selected to make that pass have a certain bar that's met. And so that phenotype, if you matched factors, if you could, for surgeons against male equivalent and then tried to answer for gender, is that fully matched or equivalent? The so-called culling effect of what's coming in. I mean, is that one parcel? If you agree, what are your thoughts on that? And maybe what else are you trying to understand as to the why?
100%. And so I think there's like so many layers here. And the first thing to say, and it relates back a little bit to what you said before this question, is I don't have all the answers here.
Mm-hmm.
And one of the keys in this space, I think, for me, is to say, I have my own blinders because of the position I sit in society as a white guy. So I don't have all the answers, and I don't presume to lead on this topic. I'm hoping to leverage my privilege to make it a wider topic of conversation and hopefully open some doors for people who have the lived experience to help us get the answers we need to fix it. So that's the sort of predicate or the premise I come from. Now, is there gatekeeping into surgery? For sure there is. Could it explain our findings? Like potentially it could completely explain it, which is to say that, men and women in medical school are maybe equally skilled at becoming surgeons. And yet, because of the culture of surgery, it's harder for women to get into surgery. And so we only take the absolute top women, and we take the top men, and then also an additional subset of men who are good but not as good, and they drag down the overall average. Could that explain it all? For sure it could. The one thing that speaks against it, and I think means that this isn't the full explanation, is that we see these results fairly consistently across all surgical specialties where there's variation in the representation of women. So when you look at things like urology, cardiac surgery, neurosurgery, which are very heavily male dominated, have a low proportion of women, the effect estimates are pretty similar to when we move to places like general surgery and plastic surgery, which have a much higher representation of women. And so even in those surgical fields that are better represented with women, we still see similar effects. So I don't think it's the full explanation. I do think it can explain some of it. But I think there's probably more going on here. And I don't think epidemiologic data studies like this are going to fully answer that. And so we've got some qualitative work going. We've got an anthropologist hired who's working on observing surgeons, asking them why they're doing what they're doing, trying to understand those processes of care. Because at the end of the day, I don't believe the presence of an X chromosome in your physician should be an explanation for why your outcomes are worse. It's something about the practice patterns and the behaviors, the interaction between patients and physicians, overall treatment decision-making processes and risk tolerance, all those sort of features about how you practice, which are in some way associated probably with a gendered phenotype that affect patient outcomes long-term. And so better understanding those practices actually provides us an opportunity for teaching, education, and like changing the way we practice. And that's what I'm hoping to get out of it myself.
I love that message because it was too easy to simplify and say, one type of physician is better. I think part of it was you today and throughout your work is displaying the data as it is, but then saying there may be a behavioral component. And that's a bit of a challenge and an optimistic outlook to say, what if gender in this case is representing or a surrogate of some type of behavior that can be unpacked through an anthropologist like you? So to be in the fly on the wall for that kind of work would be awesome. But then we bring that back and actually take some skills that maybe could be taught or learned. And I think that would really help the field grow over and above the allyship and the kind of normalizing of numbers and people in positions of influence. I think that we really want to see there may be something learned that we can have along the way. So I really like that.
Absolutely.
Optimistically.
I completely agree. I think this is it shouldn't be seen as fatalistic, right? I mean, I have some senior colleagues who say, and I just confess, when I first published this as a resident, I got an email from a physician who essentially said, if you think men aren't as good as women, you should probably just get out of this field. And I think that's not the way we should take it, right? This is an opportunity for growth. This is an opportunity for learning. We want to improve outcomes for all of our patients. We want to improve the care we give across the board. And if we can use physician sex as a surrogate for understanding better care metrics and better care practices, then I think that's a good tool to get us where we're trying to go. And it's not about men are better, men are worse. It's about understanding the best way to give care and the best way to take care of our patients.
Yeah, and I think that's really the key message is, you're presenting data. We need to be clear about its truth, that we are finding in it, especially through your meta-analysis as you've shown, but you use that to unpack things and not just be dissuaded by, that top line data. Let's understand things better. And I think we're both in it for the long haul. And in fairness, the full disclosure today, it's two men talking about this,
100%.
and we're aware of that disclosure. But I think it's important for us in our eras, representing kind of the cultures or backgrounds or minorities that we might represent to bring this conversation forward. Because as you say, we might help advance this, further. We could talk about this forever, but we are live on location at Queen's Landing, and by the time folks hear about this, you'll hopefully be able to watch Chris's talk and certainly learn a lot from this podcast as well. Chris, I want to thank you again for joining us this weekend and for carving out time to do this in this kind of in between one fern, I guess, vibe that we have here in the corner. And And it's been a pleasure to all of our listeners and viewers. Again, we had a lot of feedback this weekend, I think, Chris, from people saying, hey, I've started listening. I'm really enjoying it. So I think just wanted to thank all of them for that. Please continue to rate, review, subscribe, and let us know what you think about this and other episodes we've had. On behalf of Chris Wallace, I'm Ali Khan Lalani. Thank you for joining.